My name is Amir Ahmadi. I'm from University of British Columbia. This is SCCT 2014 in San Diego. I have a pleasure of having Dr. Harvey Hecht here, Associate Director of Cardiovascular Imaging at Mount Sinai Hospital in New York. Dr. Hecht, I start with a question about calcium scoring. In the past year, we've seen three very interesting papers from the MESA group showing how calcium score can appropriately reclassify patients with various degree of risk factors and various risk profile. However, in the most recent guidelines from ACC/AHA in 2013, the calcium score was actually downgraded. Any comments on that?
A lot of comments, not necessarily fit for public consumption. It's really incomprehensible to me and actually unconscionable that it was downgraded. The downgrading was based upon really manipulating the criteria for risk prediction to include stroke. And they said that since there was not very much data for coronary calcium as applying to stroke, it did not fulfill the criteria for being included for overall cardiovascular risk, which basically means they ignored the vast body of evidence showing that it is far and away the most potent predictor of risk, as exemplified by MESA, by the Heinz-Nixdorf study, by the Rotterdam study, in which any risk factor-based paradigm is wrong 2/3 of the time in the intermediate risk population, 1/3 of the time in the high risk population, and 15% of the time in the low risk population. Nonetheless, the new guidelines chose to totally ignore this, downgrade it from a 2A to 2B rather than upgrade it to a class 1, which it should have done. 4 years ago, in 2010, the ACC/AHA risk evaluation awarded it a 2A. Since then, there have probably been 20 major prognostic papers increasing the evidence, and yet the committees responsible for this took the opposite tack and downgraded it from a 2A to a 2B. Moreover, they excluded its application to almost everybody for whom it would be served best by saying that there are these 4 groups for which you need nothing other than using the new risk paradigm, including the entire intermediate risk population. They're saying you don't really need to do any test and reserves coronary calcium with the 2B indication only for those people who do not fall into their 4 risk categories, of which there'll really be very few people. So to me, this represents a major step backward, and it's really something that may be revisited because the new guidelines say they are just not temporary, but they are to be revisited frequently. This should be right at the top of the agenda. The most pertinent part of the new guidelines was that this is just a recommendation, but physicians should exercise their judgment. And my recommendation is physicians should exercise their judgment and ignore the new guidelines when it comes to coronary calcium. I would also suggest that this is a very fertile field for fellows to become involved with. I think that SCCT, with a certain amount of appropriateness, has emphasized CTA, but I think it's been at the expense of important work that remains to be done, both in further research on coronary calcium and in advocating coronary calcium. It has the potential to save far more lives and affect so many more people than CTA, actually. So it's been a neglected area for a long time.
So just a follow-up question on that. If you think that there is a revision in this guideline, and if you were part of the guideline writing committee, which part of the patient population, low risk, intermediate risk, or high risk, do you think will benefit most from getting a calcium score?
I think very clearly it's the intermediate risk part of it, because 2/3 of these patients are misclassified. So for the intermediate risk group, it should be a level 1 classification. There's no question about it. In the high risk group as well, if 1/3 of the patients are misclassified, then we're going to be unnecessarily, perhaps, treating many patients more aggressively than they need to be treated simply because their risk factors say they're at high risk. When it comes to the low risk population, I think it should be applied across the board to everybody with a family history for premature coronary artery disease. Absolutely, because that is a high risk group nesting within the presumed low risk population.
Thank you very much, Dr. Harvey Hecht. For more interviews with CT experts, visit us at youtube.com/FiRST in imaging. Thanks very much.